It is astonishing how often I look at mechanical ventilators in the ICU and a patient is on a spontaneous mode and they're completely dysynchronous, particularly in expiration, where their breath is either too short for them or else they're trying to get a breath, but it's just not happening. And this tutorial is about patient ventilator dysynchrony and expiration. And I'm going to introduce a concept known as the Wibbly Wobbly Waveform. I hope you enjoy it. This is a series on monitoring mechanical ventilation, and this tutorial is on expiratory dysynchrony. This time I will discuss expiratory dysynchrony due to long breaths, the Wibbly Wobbly Waveform, and expiratory sensitivity versus IE sync on Puritan Bennett ventilators. Let's start with a clinical scenario. You're rounding in the ICU and you see Tim, who's a 59-year-old who was diagnosed with community-acquired pneumonia. He developed ARDS and now he's on pressure control ventilation, or he has been weaned to volume support ventilation. The nurse says that he looks really uncomfortable. Well, what's going on with Tim in this picture? What do you identify as being abnormal? What is normally usually flat pressure waveform has a bump on the end of it known as a terminal upstroke. And this occurs when the breath is going on too long and the patient is trying to exhale while flow is still being delivered. You will notice that the inspiratory time here is 2.5 seconds. Most people inspire in 1 second, so this is a very long inspiratory time for this particular patient. The ventilator will cycle to exhalation in this situation, though, if the airway pressure increases 3 centimeters above the inspiratory pressure, that's the pressure limit, or the pressure support inspiratory pressure level above PEEP. So for example, if you have a inspiratory pressure or a pressure limit that's 15 above PEEP and the airway pressure hits 18, the ventilator cycles off. And the reason why it does this is to stop the patient damaging their own lungs while they cough or they take a double breath. The treatment for this problem is to shorten the breath. Well, how do you do that? You just roll back the inspiratory time. So now we're on an inspiratory time of 1.2 seconds, and you can see here that he has a perfect looking waveform. Now, it may well be that having shortened the inspiratory time and increased the I/E ratio, Tim's saturation may fall, his oxygenation may deteriorate, in which case you might consider an alternative ventilatory strategy, such as using bilevel pressure control with spontaneous breathing. This is covered elsewhere on my YouTube channel and on my blog. Let's look at another situation. In this scenario, Tim is on pressure support or volume support ventilation. You know that it is spontaneous because of the red waveform. Now something similar is happening here, isn't there? There is a terminal upstroke. And this is pretty much identical to what you saw on pressure control. I will point something else out here. You can see that the expiratory sensitivity, this is the percentage of peak flow at which pressure support or volume support cycles to exhalation, has been set at 15% of peak flow. If you look at the flow waveform, the peak flow is about 60 liters, but this breath has cycled off at about 40 liters, which is about 60% of peak flow. It should be cycling off at about 12 liters. So what's going on here is that the breath is too long for the patient and he is trying to exhale while the flow is still being delivered. The expiratory sensitivity is too low for this patient. Well, what are you going to do about this? You're going to shorten the breath. How do you do that? You increase the expiratory sensitivity up to a higher number. Let's try 25%. And this is trial and error. So let's see what happens. And in this situation, at 25%, he seems to be very happy. The terminal upstroke in pressure support or pressure control is the patient attempting to exhale while the ventilator is still trying to deliver a breath. Inspiration is too long. The ventilator pressure cycles rather than time cycling in pressure control or flow cycling in pressure support. In pressure control, the inspiratory time should be reduced, but if you're seeing this, you really should consider changing the patient over to pressure support or volume support. And this is an easy problem to resolve. Occasionally, keep in mind that a terminal upstroke is also seen in patients who have very large bulbar abdomens. The most common cause of this is pregnancy. But a patient who is morbidly obese, who has had gas insufflated into their abdomen or has PAX or ascites may present the same issue. And in that case, you just need to have a look at the waveforms and see, for example, if the patient is flow cycling at the percentage where they should be, in which case you're not going to be too bothered about a terminal upstroke. I want to move on now and look at something that's a little bit trickier, and I call this the Wibbly Wobbly Waveform. Let's start with pressure control. This is a patient on pressure control ventilation with a target tidal volume of 420 mils. The inspiratory time is set at 0.8 seconds. What you notice is wrong with this picture. There are two things wrong with this picture. The first thing is you can see that there is a W-shaped expiratory flow curve. Normally that just goes up like a V, but here it is a W. It goes down, it goes up, it goes down again. The other thing to keep in mind is that the flow waveform has shaved off before it has arrived at the baseline. So you have two issues. The inspiratory flow does not get to baseline, which means that the breath hasn't finished, and it looks like there's something going on in expiration. And this is expiratory dysynchrony. What it means is the breath is too short and the patient is trying to inhale while flow has ceased and cycled to expiration. And you see that in two ways, the shaved flow waveform on inspiration and the W-shaped wibbly wobbly waveform in expiration. How do you manage this? You manage this by lengthening the breath. In this case, we're increasing the inspiratory time to 1.2 seconds. And let's have a look. And now we have a perfect pressure control waveform with a tidal volume that may be a bit generous for this particular patient, but certainly it is higher than the curtailed volume that we were previously seeing. And notice how the inspiratory flow waveform goes all the way down to baseline before the patient exhales. What about this situation? Well, what mode of ventilation is this? This can only be one mode of ventilation, and this is pressure support ventilation. How do you know this? First of all, there is a decelerating flow waveform that curtails at a certain percentage of peak flow. We've set it at 30% here. And also, the inspiratory pressure limit is the same for every breath. You will note the presence of the wibbly wobbly waveform in this patient also. Again, flow goes out. Flow stops going out, it starts going inwards again, and then it goes outwards again. And this is expiratory dysynchrony. The breath is usually too short and the patient is trying to inhale while flow has ceased and cycle to exhalation. If you recall the tutorial on inspiratory dysynchrony, I overlaid the effort that the patient was making in red. So the red bit there on the flow waveform and on the pressure waveform is what the patient is doing. The trigger is that little tiny yellow triangle at the beginning of the patient's negative airway pressure. Flow in this situation, because it's a spontaneous breath, is in orange and pressure is in green. I pointed out that there was no easy way of figuring out the contribution of the patient versus the ventilator in pressure support. This is likely what is happening in the current scenario. The key item to follow is the red negative pressure waveform below each breath. The negative airway pressure that the patient is generating extends outwards beyond the pressure waveform. While this may not have an apparent effect on the pressure wave because flow has stopped due to the short expiratory sensitivity, the patient is now able to generate positive flow in the system after the inspiratory valve is closed. Hence, the expiratory waveform is indented. The way to manage this, in the majority of cases, is to lengthen the breath. We achieve this by increasing the inspiratory time or reducing the expiratory sensitivity. You'll recall that the peak flow was 60 litres for this patient with an expiratory sensitivity of 30%. 30% of 60 is about 18 litres. We're going to reduce that now to 20%, and the expiratory cycle percentage should be about 12 litres. And you can see we have a perfect looking waveform now. So we're very happy. So this has worked out well, and I'll show you a couple of examples of this. This is a patient with a horrible wibbly wobbly waveform who was on an expiratory sensitivity of 30%. Well, the thing to do here is to reduce the expiratory sensitivity. It's down to 25% and it looks even worse. So let's go down lower. Let's drop all the way down to 15%. And this looks pretty good. It doesn't look perfect, but it looks pretty good. And this patient is now not dragging gas out of the tubing when there is very little flow going on in the circuit, just the flow by. The success of this approach is determined by the operator recognizing the problem, understanding that this patient's workload of breathing has increased, and you've got to sort that out for them. But it's important to understand that there is another possibility about what's going on here. And sometimes when you see the wibbly wobbly waveform, it's something completely different. In this situation, the expiratory sensitivity has been set at 20%. In this scenario, the problem is not that the breath is too short, but too long. And the flow defect is being caused by the patient wanting to breathe in between ventilator-associated breaths. This is where you will see that little bump much later, not just immediately after the beginning of the expiratory waveform, but as that waveform has gone on and it's abutting the baseline of zero flow. That suggests, but not always, the patient may be looking to get another breath before the previous breath is completely finished. And if you suspect this, the thing to do is the opposite of what you've already done. You shorten the breath by reducing the expiratory sensitivity. So in this situation, we're turning it up to 40%, and let's see what happens. And you can see here that the patient is taking far more breaths, and those breaths are syncing up much better. So the patient has rapid breathing, and we may have to assess this, whether the patient is distressed or it is rapid shallow breathing, but at least every breath that the patient is trying to take, a breath is being delivered, which means that the workload of breathing is reduced. In most ICUs, the bedside attendant rarely changes the expiratory sensitivity, and that's an issue because the operator really needs to understand that there is a problem and understands that the patient's workload of breathing is increased. It's increased because they're not getting flow when they want it. And then they get uncomfortable and they go purple in the face. And that inevitably leads to the patient being given sedation so they can't trigger the ventilator. And that sets them back, prevents them from weaning, prevents them from liberating from the ventilator, results in their diaphragm becoming dysfunctional, their autonomic nervous system going haywire, and their body deconditioning. You need to be able to problem solve ventilator waveforms, and most of these problems can be resolved with conventional approaches. Nevertheless, this concept of expiratory sensitivity is problematic because it assumes you know what the patient is trying to do. You need to know when the patient is trying to start a breath, and you need to know when the patient is beginning to finish a breath. And that's not easy to determine by just standing looking at the ventilator. Within these ventilators, there is a whole pile of technology that is looking at flow going in, flow going out. There is flow sensors, there's pressure sensors, there is resistance sensors. And as a consequence of this, the industry has moved on and said, yeah, we can solve this problem. And this is a different way of doing it. This is where the ventilator senses the beginning of the breath, senses the end of the breath, and then uses a complex black box computer algorithm to determine when best to initiate the breath and finish the breath. On Puritan Bennett ventilators, this is known as IE Sync. It's a paid add-on currently. On Hamilton ventilators, it's known as IntelliSync. There are times when you see a waveform like this, it's just not that obvious. Yes, it appears to be expiratory dysynchrony, but is it a case of the patient getting too short a breath or too long a breath or failing to trigger a second breath? The expiratory sensitivity has been set at 20%. When I turn down the expiratory sensitivity to 10%, it looks exactly the same, if not worse. No difference for this patient. What about an alternative approach? I'm putting a cartoon of IE sync here. At this point in time, I'm only going to concern ourselves with E-sync, that's expiratory synchrony. The setup is an eye in the middle of the screen and 2 chevrons on either side. So that's 5 options for how you adjust this. You click the main button on the ventilator to make the adjustments. For the vast majority of patients, if you put them on IE sync, it works out perfectly well and saves you from even having to think about the E-sense. As in this particular case where we put it on a patient, immediately it just looked perfect. So this patient settled down really, really well without any further adjustments. And you can see the flow waveform is very pretty. Now, it is worth pointing out that if you see this flow waveform, it's very different from what you've seen on pressure support versus volume support. The flow waveform is red, but it doesn't curtail at a particular percentage of peak flow. In fact, it goes all the way down to baseline. It doesn't shave off, and this is a peculiarity to this modification, and that's part of the whole paradigm. Flow ends when the breath ends. It doesn't have to predict when the patient is exhaling. The adjustments on this particular modification to how the patient cycles to exhalation are fairly simple. If you click 1 or 2 times to the left, then the breath cycles off earlier. 1 or 2 times to the right, the ventilator cycles off later. This is a different patient with a tricky situation. As you can see, the patient is double triggering. Now, I'll talk about triggering in the next tutorial, but when patients are triggering this frequently, usually what you do is try and reduce their ability to trigger the ventilator by increasing the flow by. So what you're going to do? Well, the bedside operator increased the V-sense or the flow by to 4 liters in the belief that it would reduce the amount of triggering. But the consequence here was horrible wibbly wobbly waveform. The expiratory sensitivity is already set at a very low 20%, and this is really difficult. So let's put the patient on IE sync and see what happens, because this should resolve both problems on inspiration and expiration. When we initially put the patient on the middle zone, it really looked the same. And of course, because you think it's a problem with expiration, then the obvious thing to do is click the button to the right and give the patient a little bit more time in expiration. You can see in this particular picture, the patient on -1 still has a wibbly wobbly waveform. So let's click it to -2. And this looks significantly better. It's not perfect, but it's much better. And we know that our patient is more comfortable, they're not fighting the ventilator, and they're unlikely to get sedated because they seem to be able to trigger and be ventilated simultaneously. Here is another patient who is on VC+. This is pressure regulated volume control, volume guaranteed pressure control. And you can see that the patient has a horrible level of inspiratory dysynchrony on this particular mode of ventilation. It's unusual enough to see on pressure controlled ventilation. We put the patient onto pressure support ventilation with IE sync, and this is what it looked like. Perfect waveforms. So this is pretty impressive, and it seems to me that this is the future, certainly for the next few years, on how to get patients to synchronize better with the ventilator. But it doesn't always work because not every patient can actually synchronize. This is a live video of a patient who would not tolerate pressure support, would tolerate volume support, but had a horrible dysynchrony on inspiration, on expiration, and no matter where we set the V-sense and the E-sense, it didn't make any difference. So we put the patient in IE sync, and you can see here that the patient is still very, very, very dysynchronous. And this cannot be fixed beyond this point, but it's substantially better than what we were seeing. And at least the patient was able to breathe spontaneously and prevent diaphragmatic dysfunction and diaphragmatic atrophy. Now let's review this tutorial. This was a tutorial about expiratory dysynchrony. I started off talking about the problem of the breath being too long and the patient pressure cycling the ventilator, both in pressure control and in pressure support and volume support. And I discussed how you really need to just shorten the breath, either by reducing the I time in pressure control or by reducing the expiratory sensitivity by going to a higher number, for example, from 30% to 40%. Then I looked at the issue of the patient developing severe expiratory dysynchrony in the flow waveform during expiration that is rarely actually seen by the bedside practitioner. And I call this the Wibbly Wobbly Waveform, and it really happens for two reasons. One, the patient has not stopped breathing while the ventilator has cycled off. You need to lengthen the breath. The second time is where the patient wants to take another breath, but the flow has still failed to stop cycling. In each case, you can adjust the expiratory sensitivity to try and get rid of the wibbly wobbly waveform, and sometimes it takes a lot of fiddling to get there. The newest adaptation to modern ventilators is to add an intelligent concept to it using computer algorithms and flow and pressure sensors, and this is known as IE Sync. And it's used to map out what's going on with the patient both in inspiration and expiration. And I explained to you how you can use IE Sync to treat expiratory dysynchrony. It doesn't always work, and it doesn't always work well, but at least it seems to make the patients a lot more comfortable. Next time we'll go and have another look at ventilator triggering, and I'll discuss under-triggering and over-triggering, understanding and using flow triggering, and then using IE Sync as an alternative trigger. I'll see you then, and I guarantee you'll learn something. So that was patient ventilator dysynchrony in expiration. If you're enjoying these tutorials, don't forget to leave me some likes, subscribe on YouTube, and follow me at ccmtutorials.org.